It's difficult to, to treat hematological malignancy patients in general in the setting of COVID. We're basically taking all the precautions that have been recommended by the WHO as well as the CDC. So where nowadays, whenever we go rounding on the inpatient side or clinic, we are definitely wearing masks at all times, gloves. We minimize contact with patients, which, has its pros and cons, but I think we have to do that currently. And we're trying to be very cautious with the use of stethoscopes and washing them between each patient use thoroughly, and also between each patient use doing very thorough hand washing for 30 seconds with soap and water. I mean, things that, we always should be doing, but really now we're making a effort to try to do this 100%, given the risks to ourselves and to other patients. Specific to treatment for AML, I think initially during the period of end of March to, let's say, end of May, we were being very cautious, especially for doing allogeneic stem cell transplant in patients with AML. So patients who were in remission, who seemed like they were having a good, deep response, and we could hopefully continue to maintain that response, we would give them 1 or 2 cycles of consolidation and try to defer the transplant. Now in June, we have started transplanting back to our normal numbers, and we've actually luckily seen that most of those patients where we delayed the transplant have maintained their remission with continuation of consolidation. So that was one very objective, direct change that we made. The second was probably in the area of immunotherapy. So, given that with COVID, we know that a lot of the end organ damage or pathology comes from inflammation, high levels of CRP, inflammatory markers, T cell activation. We actually had held enrollment to a number of our T cell enhancing strategies, such as the immune checkpoints, the CAR T cells, bispecific antibodies, because we were worried that these could either exacerbate or could be hard to differentiate between immune toxicity from these drugs and COVID. We have luckily not seen any problems with some of the patients who had already received CAR Ts and bispecifics before the COVID shutdown, and now we've kind of restarted those approaches. I think protocol-wise, we did kind of slow down accrual to protocols, and that was not by design. We just had less patients wanting to travel to our center because we get about 70% of our patients at MD Anderson coming from outside of a 100, 200 mile radius, and half or more actually come from other states. So part of it was, unlike almost all other cancer centers or hospitals in the country where most of their catchment, 90-95% is regional, ours almost 70% is outside of the region. So those patients didn't want to travel. So we actually did a lot of telemedicine, both for patients who are already on studies, oral agents where we were able to ship the drugs, keep them on study. The FDA, the pharma companies, our IND, IRB at MD Anderson were extremely supportive. They allowed us to have waivers, of course, with very clear documentation and labs at home, but we were able to keep all those study patients on protocol and not incur major deviations, violations. And then we also did a lot of phone and email interactions with community doctors, other academic centers, because a lot of them who would have sent the patients to us were having to manage the frontline treatment, start patients on treatment, and we gave a lot of our protocol guidelines, dosing regimens, new oral agent combinations so that they could use them. So, I mean, the silver lining is it's actually, I think, enhanced the communication and the interaction between community doctors and us. And I think, we had to use more and more of the community local academics, which may be very nice in the future as well, where we're now starting to think about doing some of these trials in other centers. We have a lot of MD Anderson outreach and branches, and could we then start using them? Of course, the patient may have to initially come to us, be enrolled, but maybe instead of coming once a month, they could come once every 3 and 6 months. And then our collaborators at the regional MD Anderson branches maybe could help out. So I think there may be some positives in the way of diversifying research and, having it done more on a regional scale with collaborations with the main centers. And of course, the other thing has been, the use of virtual frameworks for a lot of educational activities as well, for steering committee meetings, advisory meetings, protocol discussions. And we thought a lot of these would have slowed down, but I think actually everything is pretty much going at 90 to 100% of the speed it was. And, we're still opening new protocols. We're still having activation visits. We're still continuing to do drug development discussions. We're interacting with the FDA. So I think things are at this time, kind of back to normal. Our patient numbers have started to go back up. Of course, unfortunately, in Texas, it looks like the peak is coming much later. So we're actually now starting to see the highest number of patients per day in Houston compared to what we had 2-3 months ago. So we're going to have to be a little bit careful because people may be a little bit complacent based on what's happening in other centers that already went through their peak, and it's possible that we will have a delayed peak. And then, of course, there's a lot of excitement because some of the vaccines are already moving into a phase 3 studies, and we're hoping that, maybe by the end of the year we could start doing large-scale vaccination for our patients first, and then also for all the healthcare providers. So I would say, it hasn't really slowed down the AML treatment or really changed our standard of care in any way. It has slowed down enrollment to clinical trials, which is unfortunate because those trials usually lead to new breakthroughs and approvals that a year or 2 years from now could potentially save thousands of lives. So hopefully we will get back to enrolling on those trials, whether we do it all at the main centers like before, or maybe diversify and have more collaborative trial resources. And luckily, we did not have too many direct COVID patients at our center per se. So we don't have the experience, but that's one experience we don't really want to have. So that's a good thing. And so far we're doing quite well. So our mortality rates have been very, very low in the patients we did have with COVID, which is actually very pleasant surprise compared to what we had seen from some of the initial reports from China and other areas showing 20-30% mortality. We've had less than 5%. And I know some of the big New York centers also have had 5% or less in some of their heme malignancy patients, which is good. We don't know why we're seeing so low incidence in the heme malignancy patients. There's a couple of hypotheses. One is that maybe these patients are already extremely stringent on taking, precautions. That is true, and they probably took it very, very seriously even in the early March, and maybe they just were, homebound for the whole time. And the second is there may be some component of immune suppression or less active immune systems in some of our acute leukemia MDS patients, which may result in less immune-mediated damage. We don't know for sure, but these are kind of the things we've seen. But so far, we've been pleasantly surprised, and hopefully we'll continue to see low rates of infection and low severe and fatal outcomes in our heme malignancy patients, at least in Houston.